This case is directed to radiology residents, but I'm sure people interested in neurology and juniors would benefit as well. This is the CT scan of the head on the same patient about 2 weeks ago. As you see, there is acute intraparenchymal hemorrhage with surrounding vasogenic edema. Bleeding has various stages which may affect the appearance on MRI, and this is the reason to show this case. Hyperacute blood occurs within the first day and is mainly composed of oxyhemoglobin. Acute bleeding occurs within 1 to 3 days and is mainly composed of deoxyhemoglobin. Early subacute blood occurs between 3 days and 1 week and is composed of intracellular methemoglobin. Late subacute blood is mainly composed of extracellular methemoglobin and occurs about 1 week to 1 month later. Chronic bleeding more than a month degrades into hemosiderin. Now, each stage of bleeding has a different appearance on MRI. How would you know if this subacute bleed is early subacute or late subacute? An easy way to do that is to look at the T2 weighted image. The center of the bleeding is very bright on this T2 weighted image, denoting that we are at the late subacute stage. From combining the T1 and T2 images, you know that this bleed occurred more than a week and less than a month, even without looking at the CT scan. Another important piece of information is that chronic bleeding, hemosiderin, is extremely dark on both T1 and T2 weighted images. And as you see here on the T2 image, the rim is extremely dark, consistent with the formation of hemosiderin at the edge. To confirm, the rim is relatively dark on the T1 weighted image as well. Now here is a sequence that we call susceptibility weighted image, which is a very useful image when you're thinking about bleeding or calcifications. On this sequence, with blood or calcium, you'd see a very dark kind of artifact. Hemosiderin is famous for giving susceptibility artifacts, such as what we see here. Now, this is nice and neat, and it's a good review of basic MRI imaging. However, the main point I want to show is going to come next. Many people when doing brain MRI would depend only on the susceptibility weighted image to confirm or exclude the presence of blood. Although that's a useful technique, there is a pitfall. I would direct your attention to the center of the bleeding, which we described as being subacute in nature. As a radiology resident, especially seniors, you have to remember that late subacute bleeding does not give you susceptibility artifact. To make this easier to remember, let's go over an important fact. You remember how we said on the T1 image that bleeding is bright in the early or late subacute and it's iso or hypointense otherwise? Let's do the same with T2. On T2, bleeding is bright on the hyperacute and the late subacute phases only. So remember, whenever bleeding is bright on T2, there is no susceptibility artifacts. That means you would not have susceptibility artifact when the bleeding is in the hyperacute or late subacute stages. Let's go over this again. The central area that is subacute in nature that appears bright on T2 would not give you susceptibility. However, the peripheral area that gives you chronic hemosiderin would be expected to give you susceptibility. So let's switch from this T2 to the susceptibility weighted image. And here's a center that's bright without artifact and a peripheral area that shows you the artifact. This was a good case to review the various appearance of bleeding depending on which stage you're looking at. And more importantly, to emphasize the fact that not all bleeding would show susceptibility artifact on susceptibility weighted imaging. In particular, when bleeding is bright on T2 in the hyperacute and late subacute stages, there is no susceptibility to be seen. Thank you for watching. Send us your comments as usual. More cases later. Another observation is the widening of the carina, the bifurcation of the trachea here. A third observation is the presence of two borders along the right cardiac shadow. All the described signs are the classic signs of left atrial dilatation. So straightening of the left cardiac border, or bulging, is the first sign. The second sign is widening of the carina, and the third sign is a double contour along the right cardiac shadow. Please note that widening of the carina is a very late sign, so look for the straightening or bulging along the left side or the double contour. Now another neat point in this case is the presence of these dilated vessels in the upper lung. Due to the effect of gravity, the vessels in the upper lung should be smaller in size compared to those in the lower lung, which is reversed in this case. This abnormal finding is known as pulmonary venous congestion, vascular redistribution, upward diversion, or cephalization. This sign denotes that the pressure or volume in the left-sided heart is so high that the venous system cannot return the blood normally. The final diagnosis in this case is mitral valve disease, namely stenosis, due to rheumatic fever in a young patient. So there's secondary left atrial dilatation and pulmonary venous congestion due to the presence of mitral stenosis. The teaching point from this case is to remember that in a normal patient who is standing, the vessels in the upper lung should be smaller than those in the lower lung. If the vessels in the upper lung are equal or larger than those in the lower lung in a patient who is standing, that's a sign of pulmonary venous congestion. The second teaching point is to remember the signs of left atrial dilatation in the form of straightening or bulging of the left cardiac border, double contour on the right side, and widening of the carina. Thanks for watching. More cases later. This is a good practical case. A 68-year-old male patient who was involved in trauma. We already know that CSF in sulci should appear very dark, and this is not the case in this region. So these bright lines filling the sulci are consistent with bleeding, and since this is within the subarachnoid space, this is subarachnoid hemorrhage. Now take a look at this again. Now let me show you the follow-up CT only 7 hours after the initial scan. The follow-up CT shows a subdural hematoma that tracks along the falx cerebri, is seen along the lateral aspect of the brain. The subdural hematoma also tracks along the left tentorium. The previously seen small amount of subarachnoid hemorrhage is still noted. However, the absence of sulci on the left side compared to the right is not only due to that. Notice how you have CSF-filled sulci on the right side compared to the absence of them on the left. This is called sulcal effacement, a sign of mass effect. We learned from a prior case that subdural hematoma does not respect the osseous sutures. We also learned that subdural hematoma tracks along the falx without crossing the midline. It also tracks along the tentorium without crossing it. The important question here is, was this subdural hematoma present on the initial scan? And if that's the case, where did we go wrong? Now let's go back to the initial CT scan where we saw the small subarachnoid hemorrhage. What we learned from this case is that we have to be very vigilant with cases of trauma. In particular, make sure you don't have any intracranial bleeds. That means that you have to take your time in looking at these cases and search for subtle findings as well. In retrospect, the first hint to the presence of a subdural hematoma is the unusual asymmetric thickness of the falx cerebri. Notice how you have an asymmetric thick falx posteriorly, especially on the left side, which does not involve the right side. Another important thing to do is to look at the CSF spaces, especially at the periphery. So let's do that on the right side and then look at the left. You'll notice that the subarachnoid and subdural space is clean. By clean, we mean that you have very dark CSF density without bright material to denote the presence of blood in these spaces. Now let's look at the abnormal left side. And by doing that, you'll notice that there's some area of high density within the subdural space. This may be difficult to see, and that's why adjusting your windows a little bit might help you in searching for such subtle abnormalities. Another very difficult finding here is the asymmetric appearance of the CSF spaces on the left compared to the right. Note how you have wide CSF spaces on the right in the form of sulci compared to those on the left, which are partially effaced. Although a tough finding, on retrospective evaluation, this was probably early mild mass effect. Another thing that you have to do when you look at any kind of CT is to look at the reformats, whether coronal, sagittal, or others. The coronal reformat is very useful to look at in cases of trauma. And one of the things that you have to concentrate on is the thickness of the falx and tentorium. Remember how we described a small subdural hematoma as asymmetric thickness of the falx? You have the same finding concerning the tentorium. The tentorium on the left side is thick compared to that on the right, and this is due to tracking of subdural hematoma. Remember that subdural hematoma tracks along the tentorium without crossing it, so it's usually confined to the supratentorial or infratentorial space. So let's summarize the few teaching points that we learned from this case. We talked a little bit about subarachnoid hemorrhage and subdural hematoma and how they look different on a CT scan. More importantly, especially for residents reading the CT scan on call, is to be very careful when assessing cases of trauma. By that we mean that you have to look for very subtle signs of intracranial hemorrhage. First of all, make sure that your CSF spaces, the sulci, are symmetric bilaterally to exclude mass effect. Second thing, make sure that the falx is not thickened by bright material, especially in an asymmetric fashion, and that stands true for the tentorium. A practical way to do that is to look at the coronal image, where asymmetric thickening of the falx or unilateral thickening of the tentorium is easier to appreciate. Also, make sure to be very careful when assessing the edge of the brain. Make sure that the CSF spaces are dark and clean. That the adjacent dense bone may obscure underlying minimal amounts of bleeding, so change the window to have a better ability in detecting these abnormalities. If in doubt, calling the abnormality along with clinical observation and a follow-up CT scan is a reasonable way to go. Thank you for watching. See you with another case. This is a 55-year-old male patient who was treated for colon cancer. I'm showing this case to mainly concentrate on the appearance of the liver. The first observation is that this is a CT scan without contrast. Despite of that fact, you could clearly identify the intraparenchymal vessels. The reason you see the vessels is not because the vessels are enhancing, it's the opposite. It's because the surrounding hepatic parenchyma is very low in density. The most common reason to have diffuse decreased hepatic density is a fatty liver or what's known as hepatic steatosis. The differential diagnosis includes infiltration by neoplastic processes such as metastasis or by substances such as amyloid. Hepatic steatosis is by far the commonest reason to encounter diffuse decreased hepatic density. So how do you diagnose hepatic steatosis on a pre-contrast CT? Subjective ways of doing that is to notice the diffuse decreased hepatic density on visual assessment and to see the vessels as relatively bright as we described. A more objective way is to compare the density of the liver to that of the spleen. On a non-enhanced study, the density of the liver should be brighter than that of the spleen. By measuring the Hounsfield units, if the number of the liver is less than that of the spleen by 10 or more, that's usually hepatic steatosis. In this case, the measurement of the liver is 22 and of the spleen is 50, which is consistent with our diagnosis of fatty liver. Please note that this rule does not apply if you have intravenous contrast administration, since the spleen would enhance in that case. Whether it's contrast enhanced or not, the density of the liver should not be lower than 40 on CT scan. To summarize, low density of the liver could be due to hepatic steatosis or other causes. Steatosis is the commonest. Visualizing a lower attenuation of the liver and clear distinction of the hepatic intraparenchymal vessels are signs of steatosis. More objectively, on unenhanced CT scan, the density of the liver should not be lower than 10 compared to that of the spleen. Remember that this rule of comparing the liver to the spleen is performed on unenhanced CT scan. Finally, you could use an absolute measurement of less than 40 to diagnose hepatic steatosis, whether it's with contrast or without contrast. This was a good case for juniors, but also seniors. Remember that forgetting the basics or not knowing them is the thing that could harm you most in the exam. Finally, this is the patient's CT a few months earlier before administration of chemotherapy showing normal hepatic attenuation. This is to remind us that chemotherapy could transform a normal liver into a fatty one. Thanks for watching. More cases later.